Welcome back to the deep dive. So today we are talking about something. Well, it's not just a medical procedure. We're talking about navigating a biological minefield.
That's a very good way to put it. We're looking at the neck, and in the neck, millimeters are literally the difference between a cure and, say, a catastrophic stroke or permanent paralysis.
Exactly. And to guide us through this, we've got some really specific sources. We're looking at surgical protocols for what's called a radical neck dissection, or R&D, and also some high-yield revision notes for the FRCS exam.
Which is the Fellowship of the Royal Colleges of Surgeons. And that puts a really interesting spin on this. We're not just looking at the how-to, we're looking at that how not to fail. These notes are designed to test a surgeon's judgment under, well, extreme pressure. It's all about knowing where the traps are.
So our mission today is to unpack this procedure. We'll get into the anatomy, some of the specific rules surgeons have to follow, like this two-finger rule, which I found just fascinating, and really why this surgery is such a goldmine for testing a surgeon's knowledge.
And honestly, even if you never plan on holding a scalpel, the logic here is just incredible. It's risk management in its most, physical form.
Right.
You have to be radical enough to get the cancer, but precise enough to save the patient's quality of life.
Okay, so let's start with the basics. Why is this surgery even happening? The sources point to one big culprit, squamous cell carcinoma.
Right, specifically metastatic SCC. So this is cancer that usually starts somewhere else in the head and neck, the tongue, the throat, the larynx, for example. The problem is it loves to travel.
And its preferred travel method is the lymphatic system.
Exactly. It uses the lymph nodes in the neck as stepping stones, and once it hits those nodes, survival rates drop. So the idea of a radical dissection was basically a scorched earth policy.
So you're removing all the lymph nodes.
All of them. Levels I through V, the whole side of the neck. But here's the kicker. To get them all out, the classic radical procedure doesn't just take the nodes. It also takes 3 major non-lymphatic structures.
And this is where it gets really intense. You're sacrificing the sternocleidomastoid muscle. That's the big strap muscle in your neck, right?
That's the one. And you're also taking the internal jugular vein and the spinal accessory nerve.
Wow. The main vein draining blood from the brain, the muscle that turns your head, and the nerve for your shoulder.
It's a massive anatomical sacrifice. Now, in modern surgery, we try to avoid that. We do modified dissections, but for the exam standard, this is the baseline. You take everything to make sure the cancer is gone.
So what does this look like for a patient who walks in? The notes mention a hard, fixed neck mass.
Yes. And it's often painless, which is the scary part. People ignore it. But that word fixed is the key. If a lump moves around, that's usually a good sign. If it's fixed, it means the cancer has glued itself to the structures around it.
And that's the signal you have to go in deep.
That's the signal.
So let's step into the OR, the first cut. The sources mention a McPhee, or modified Schobinger incision.
Yeah, those are just specific patterns for the skin incision to get good exposure, but also, good blood supply for healing. But the moment you cut, you have to find the right plane. The notes are very specific about the sublatissimal plane.
Okay, unpack that. Why that plane?
So right under your skin, you have this thin sheet of muscle called the platysma. The notes even correct the spelling, P-L-A-T-Y-S-M-A.
I love that. Surgeons are sticklers for detail.
Oh, absolutely. So you go under that muscle, subplatysmal, because it's naturally a vascular plane. There aren't many blood vessels. It's the safe zone to start in. You're not bleeding everywhere.
It's like peeling an orange. You get under the rind without piercing the fruit.
That's a perfect analogy. And once you raise those flaps of skin up and down, you are staring at the gatekeeper of the neck, the sternocleidomastoid muscle, the SCM.
This muscle seems like the North Star for the whole operation.
It is. It divides the whole neck diagonally. Everything is defined by where it is in relation to the SCM. But here's where the protocol gets really specific, and it's the big exam point. You have to divide the SCM 2 finger breadths above the clavicle.
2 finger breadths. Not centimeters, not an inch. 2 of your own fingers. That seems so analog.
It is, isn't it? And they'll ask you in the exam, why? Why not cut it right at the collarbone?
And the answer is
protection. Directly underneath that lower part of the muscle, that's where the common carotid artery is. If you just cut blindly down at the bone, you risk slicing right into the main blood supply to the brain.
So your fingers act as a safety ruler to prevent a stroke. That's incredible.
It is. You leave that little stump of muscle as a cushion, a physical buffer over the artery. It's a built-in safety margin.
The notes also mention something called Erb's point. What's that?
Erb's point is on the back border of the muscle, about halfway up. Think of it like a junction box where a bunch of sensory nerves pop out. It's a landmark, a danger sign, that tells you you're entering a zone where the deeper, more important nerves start to surface.
Okay, so let's move deeper. SCM is cut. We're entering what I'm calling the vascular danger zone. We're at the carotid sheath.
Right. The sheath is this fibrous wrapping that holds the 3 big pipes together. You've got the internal jugular vein, or IJV, on the outside.
Laterally.
The carotid artery on the inside, medially, and then tucked right in the back between them is the vagus nerve.
And a radical dissection means the jugular vein has to come out. The notes talk about ligating it, tying it off.
And the order you do it in is absolutely critical. The rule is ligate it low first, tie it off at the bottom.
Why the bottom first? 2
huge life-threatening reasons. The first is tumor embolization. As you're manipulating everything, you could break off little clumps of tumor inside the vein.
Yeah.
If the bottom is still open, they go straight to the heart and then the lungs.
Whoa, so you seal the exit before you start remodeling the house.
Exactly. The second reason is even more immediate. Air embolism.
Air.
Yes. The pressure in those big neck veins can actually be negative. It can suck air in.
Like a vacuum.
Precisely. And an air bubble in the bloodstream is, well, it's fatal. It gets to the heart, gets turned into a froth, and blocks blood flow to the lungs. You get sudden cardiovascular collapse. So you tie the bottom first to prevent that vacuum.
That is a terrifying pun. Turned into a froth. Speaking of terrifying, there's another term here, carotid blowout.
That is the surgeon's absolute worst nightmare. It's usually a late complication, days or weeks later, often in patients who've had radiation, which weakens the tissues.
And what actually happens?
The wall of the carotid artery just gives way. It ruptures. It's a massive, often fatal hemorrhage.
Is there any warning sign?
Sometimes. It's called a sentinel bleed. A tiny, unexplained trickle of blood from the wound. It's the dam showing the first crack. If you see that, you run to the operating room. No questions asked.
Okay, we've navigated the vessels, we've avoided the blowout. Now we get to the part of the notes that is clearly the examiner's favorite topic, the nerves.
Welcome to nerve roulette. This is where the exam questions get really tough because each nerve has a specific job and a specific devastating penalty if you cut it.
Let's run through them. First up, the big one, spinal accessory nerve, cranial nerve 11.
Right. In a true radical dissection, this one is sacrificed. It controls the trapezius muscle.
And the consequence is shoulder syndrome.
Yeah.
What does it actually mean for a person's life?
It's debilitating. The trapezius muscle holds your shoulder up. Without it, the shoulder just droops. It causes constant dragging pain. And functionally, you can't lift your arm above 90 degrees, you can't brush your hair, can't reach a high shelf. It's actually cited as the single biggest negative impact on quality of life from the whole surgery.
That's a huge price. Okay, next, marginal mandibular nerve.
A branch of the facial nerve. It runs right along the jawline. The rule here is to stay a finger breadth below the mandible to avoid it.
Another finger measure. And if you slip,
The asymmetrical smile. The nerve pulls down the corner of the lower lip, cut it, and that side of the lip stays up when they smile. It's a permanent crooked smile.
a very visible reminder.
Okay.
Hypoglossal nerve, cranial nerve 12.
The hypoglossal highway. It controls the tongue.
There's a weird detail here. The notes say if it's injured, the tongue deviates towards the side of the injury. That seems backward.
It's a classic exam question. So think of your tongue pushing straight out. Both the left and right sides are pushing forward with equal force.
Okay, like a tug of war, but a push of war.
Exactly. Now, if I paralyze the right side, it can't push anymore. It's just dead weight. But the healthy left side is still pushing hard, so it overpowers the weak side and shoves the tip of the tongue over to the right.
Ah, so the tongue points to the problem.
It points to the lesion every time.
What about the vagus nerve? It's in the sheath.
The vagus is the wanderer. In the neck, if you damage it, you knock out the recurrent laryngeal branch. That means you paralyze a vocal cord. The patient gets a hoarse, breathy voice.
And the phrenic nerve.
Runs right over a deep muscle called the anterior scalene. It controls half of your diaphragm. Cut it, and that half of the diaphragm is paralyzed. It shoots up into the chest, and the patient is constantly short of breath.
Last one on the list and has a great mnemonic. Yeah, the sympathetic chain and Horner syndrome.
PMAE. The sympathetic chain runs very deep, right up against the spine. If you get that deep and damage it, you get Horner syndrome.
Break down PMAE for us.
Okay. P is for pitosis, a droopy upper eyelid. M is for meiosis, a constricted, tiny pupil. A is for anhidrosis, which is a lack of sweating on that side of the face. And E is for enophthalmos. The eye looks sunken in.
So you walk into the recovery room and see one droopy, dry, sunken eye with a pinprick pupil. You know exactly what happened.
You know exactly what you hit. It's a very distinct clinical signature.
It's wild that a cut in the neck can change the way an eye looks.
Yeah.
Now, we have to talk about geography. The notes stress that the left side of the neck is different. Why?
This is a huge point. If you're operating on the left side, you have an extra danger, the thoracic duct.
The main drainage pipe for the whole body's lymphatic system.
Correct. It comes all the way up from your abdomen, carrying all this fatty fluid called chyle, and it loops over and dumps into the big veins right at the base of the neck, but only on the left.
What happens if you nick it?
You get a chyle fistula. And you're not leaking blood, you're leaking liters of this milky fatty fluid. It causes severe malnutrition, electrolyte problems, and it prevents the wound from healing.
And the fix is to transfixligate it.
Meticulously. You have to sew it shut completely. And the note here is blunt. In an exam, if you're asked about a left neck dissection and you don't mention the thoracic duct, you fail.
Instant fail.
On the spot. You're considered unsafe.
Which brings us to exam mode. It seems the test isn't just can you do the surgery, but can you explain why?
It's the Viva format. They grill you on the why. Why 2 fingers above the clavicle? Why do you divide the submental fat in the midline? They want to hear the anatomical logic.
And using the right words is critical.
Oh, absolutely. You don't cut a vessel, you ligate it. The tissue you take out is the specimen. If you use layman's terms, you sound like you don't belong there.
The notes even mention a drawing test.
The dreaded drawing test. They hand you a blank diagram of the neck and say, draw the course of the spinal accessory, hypoglossal, and marginal mandibular nerves.
From memory.
From memory, it proves you have a 3-dimensional map in your head. You can't fake it. If your line is a centimeter off on the paper, that's a paralyzed shoulder in real life.
That really puts it in perspective. So we've unpacked this brutal surgery. It's a balance, isn't it?
It is. It's a balance between the radical cure getting every last cancer cell out and functional preservation.
Try not to leave the patient with a drooped shoulder or a crooked smile.
Exactly. And because of those high costs, especially the shoulder from losing the accessory nerve, we've evolved. We now do more modified or selective dissections.
Meaning you try to spare what you can.
If the nerve isn't involved, we spare it. If the vein is clear, we leave it. We try to move away from the scorched earth approach if it's safe to do so.
So the radical is the foundation you have to know to understand all the modifications.
You have to know the extreme to understand the compromises.
Which brings me to the final thought I want to leave everyone with. We live in this age of robotic surgery, of AI diagnostics. But at the core of this unbelievably high-stakes procedure is the 2-finger rule.
It's striking when you think about it.
I mean, just picture it. The thing standing between a successful surgery and a massive stroke isn't a laser or a GPS. It's a surgeon, placing 2 of their own fingers on a patient's collarbone to measure where to cut. It's a reminder that medicine, at its heart, is still about human touch.
And that deep internalized map of the human body, no machine can replace that.
Thanks for diving deep with us into the anatomy of the neck. It's a reminder of how incredibly complex our bodies are.
A pleasure. It gives you a whole new appreciation for what's going on just under the skin.
We'll catch you on the next Deep Dive.